I want to thank John James, the Chief Executive of the Sickle Cell Society, for speaking to the meeting this evening. I've known John for a very long time. We worked together years ago in King's College Hospital, and sadly, he's told me that some of the problems we experienced at that time about the treatment of people with sickle cell and racism is still a prevalent problem in around the treatment of people with sickle cell disorders, which is a very tragic thing to find out. We sometimes assume that things heal and people behave better, but clearly there are still problems which are totally unacceptable. But John, over to you. It's really great for you to be speaking tonight, and also the fact that a couple of days ago it was World Sickle Cell Day, and so it's great that you're speaking to us so close to that international event. So
thank you very much, Malcolm, and good evening to all of you who are on the call this evening. I've had the pleasure of knowing Malcolm for many years, as he said, when we worked together when I was at King's College. I haven't got any slides for you today, but I'm going to cover two things that Malcolm had asked me to share with you. One was the issue of the impact of COVID-19 on the sickle cell community. And the second point, which Malcolm touched on, is the issue of care and health outcomes for people who live with sickle cell in London and beyond. So I'm going to cover both those two issues. And it is, as Malcolm says, relevant to timing, in the sense that it was World Sickle Day only a day or so ago. So it is relevant. Let me start with the impact of the coronavirus pandemic on the sickle cell community. Now, I have to put my hands up and say that the Sickle Cell Society were really worried when the pandemic hit, because the immune systems of people with sickle are not as strong as other people, and we thought that the impact would be very significant in a negative way, given what was happening across the country. So what we initially decided to do, and not many people are aware of this, but we nudged government to ensure that people who lived with sickle cell were included in the category for shielding. And that nudge was important because, as ever with sickle cell, sometimes governments forget or neglect this particular condition. So our objective initially was to ensure that people living with this condition were in the group that had to shield when we roll back to the beginning of the pandemic. The second thing that was important to us as a patient advocacy organisation was trying to get real data about mortality and the impact of the virus on the sickle community, because we were scared. And to do that, we worked with the healthcare coordinating centres. That's shorthand for saying all the specialist sickle cell centres in London, whether that's King's, Guy's, the Whittington, UCL, all the centres across the London, then decided to collect data to have real evidence, real world evidence of the impact of sickle cell. And that data was collected from March, so the time that lockdown was started, and the data went up to 2021. The data has been collected since 2021, but I haven't that data in front of me at the moment. So really the good news, and I'll just share with you what that data showed. And that data came from the National Hemoglobinopathy Panel. That's the collective of all the specialist centres. And this is specifically for people who had sickle cell anemia. And what the data revealed, that data from March 20 to January 21, was that nearly 100% of the patients, the actual figure was 97% of patients with proven or suspected COVID survived. And that was really good news. So the vast majority of people living with sickle cell, 97% with proven COVID or suspected COVID during that period survived. That was the first highlight. The second highlight was that 2/3 of all patients with COVID-19 were managed at home, and most of the cases in that period were clinically mild, so less serious than what was being reported about with ventilation and so forth for other members of the population. The third point was that very few children were infected with the virus, and indeed children didn't require respiratory support, and at the time, so that's March to January, no children had died from COVID. And I guess what those 3 points tell us is that it is similar to what was seen amongst the general public and people with other conditions. So in other words, few children were infected, didn't require respiratory support, very few deaths generally for children with sickle cell, and most people who got COVID survived. Now that was at the outset, and data still being collected and will be published by the Society in due course. Then we got to the point of the vaccination programme. It would be fair to say that we had to do a lot of work with clinicians from the specialist centres and patients who were chosen to be vaccinated to encourage our sickle cell community to get themselves vaccinated. We had people from the Joint Committee for Vaccinations and Immunisations come and talk to patients, because it was felt really important. There was a lot of misinformation and anxiety. So this wasn't anti-vax, this was people genuinely not sure whether to take the vaccination. And so we spent a lot of time supporting people and encouraging them that the evidence suggested that they should get vaccinated. And what was interesting from that work is at the time of the vaccination program, there was a look at the data again, and interestingly, it showed that the people attending hospital or being admitted to hospital had changed from just those initially who had or had COVID or suspected COVID to ones who were unvaccinated. So the higher proportion of people being admitted to hospital with COVID were from an unvaccinated cohort of patients. And we use that data to say, look, you know, whatever your personal view is about vaccination or not, whatever your personal view is, here is the data saying that the most recent admissions to hospital are from people with sickle cell who haven't been vaccinated. So in all, we were relieved, is probably the best way of describing it, Malcolm and colleagues, relieved that the impact of COVID, particularly on mortality, was not as serious as we expected. It's also worth saying that that was the position internationally. So there'd been similar work done in the United States, which has, nearly 150,000 people with sickle cell, in Latin America, in Europe. So France has similar numbers to the UK, and it was a similar pattern across those countries, with probably a slight deviation in the sense that if you're not insured in the United States, then that poses other problems for you. So in summary, on the first point about the impact of COVID, particularly in relation to mortality, there were people who died. So let's be clear, there were people who died, but they were small in number, and the ones that did die, back to my point about similar to what is seen in the general public, the ones who did die had other comorbidities that contributed to their sad passing. But we also, as a society, did a survey of patients about shielding, about the impact of shielding, because those were very difficult times. And the really interesting highlight of that survey was that nearly 90% of the people that we surveyed said that the impact of COVID and shielding had been damaging to their mental health and well-being because of the isolation, not being able to go out. Some didn't have strong family support networks and things like that. So, and we recognize this. So a message from that survey is the impact of shielding on one's mental health and well-being, which again was similar to the national picture. We're now in the phase of the government's learning to live with COVID. That's government policy. We can't do anything about that. But we have been clear in our advice to patients to remain cautious because COVID is still with us, and even in the recent week or so, the number of infections are on the rise, even though the good news is they're not requiring hospitalization and serious treatment. So that's the overview of the impact of sickle cell, and it is one of relief from our perspective, but also acknowledgement of the small number of people who sadly passed away. So so what I'll do, Malcolm, is I'll just deal with the other point which you touched on about race and care for sickle patients in a moment, and then draw breath, and happy to take comments and any questions.
Thank you.
Is that okay?
Yeah, it's fine. Good.
Okay. So the next thing, and Malcolm knows this because Malcolm will have witnessed, as I did, when we were both at King's, the terrible, and I have to tell you, it was really terrible treatment of young men and women with sickle cell at that hospital. And some of you may be aware that there was a death of a young man called Evan Nathan Smith at North Middlesex Hospital about 3 years ago. And there have been many avoidable deaths of people with sickle cell from our perspective. But after Evan's death at North Middlesex, and you have to remember, North Middlesex is a trust that has been seeing people with sickle cell for decades. They've got big numbers. It's not 3 or 4. They've got a sizable sickle cell population. So for that to happen was really a tipping point, not ignoring avoidable deaths in the past, but saying how could this happen? And the circumstances of his death were serious. So as a result of that, we run the secretariat for the all-party parliamentary committee. And Pat McFadden MP, who's an MP from Wolverhampton, he took over from Diane Abbott, MP, became the chair of that. And we decided, and he decided, that we really should do a select committee type of inquiry to find out what the current status and of experience of patients living with sickle cell was. And he took evidence. He took written evidence and he took oral evidence from patients with sickle cell, from carers, whether they're parents or partners or any carer, as well as healthcare professionals. And the evidence came from London, the East and West Midlands, Bristol, Manchester, Liverpool, Ipswich, Norwich, which just reflects that sickle is all over the country. There's not part of the country where sickle doesn't exist. So that evidence highlighted 5 key points. One was, and this goes to Malcolm's point, there is continued substandard care in accident and emergency. So when Evan Nathan Smith died at North Mid, nobody from A&E or on the ward had told the haematologist that he was admitted. So the first thing is substandard care on general wards and in A&E. And let me give you an example of that substandard care. In England, we have had NICE, that's the National Institute of Clinical Excellence, guidelines for the administration of pain relief to people with sickle cell within 30 minutes. And that's the guideline, and it's been in existence for decades. We helped NICE comply that, sort of compile that standard. Under a third of trusts meet that standard. And I think that you have to ask yourself, why is there such lack of compliance, particularly in A&E, about that? And one of the reasons for that is racial bias. So it's clear from the evidence, I'm not just saying this, it's clear from the evidence that young Black men and women are seen as troublemakers, noisy, aggressive, and the other one was drug seekers. Oh, well, you want more morphine or ketamine or whatever the opioid that may be used to reduce the pain. So that is still there. The ward, the general ward element, and Malcolm will know this from our days in South London, is if you're admitted to a general ward, that is not necessarily sickle cell expertise. So you are being seen by nurses and doctors who may not be particularly well educated or trained around caring for somebody with sickle cell. And let me, and I don't like reusing this example, but Evan Nathan Smith was on a general ward and called 999 from his hospital bed because nobody believed he was deteriorating and he was in pain. And I'll give you another example, a death last year, an avoidable death, where the staff, again, general ward, where the staff thought he was being troublesome and they called security. This was somebody who was having a crisis and security is called rather than a focus on the care. So that was found, and again, consistent, it wasn't a London issue, this was the experience of patients across the country. The second headline from the all-party parliamentary group's report was a failure in coordination within hospitals. So that was departments not talking to one another and not everybody being clued up about sickle cell. That was the second one. The third issue, which goes to my point about general wards and A&E because of rotations, low awareness of sickle cell amongst healthcare professionals and inadequate training. The fourth was negative attitudes towards sickle cell patients. That's the racial inequality element that I've talked, disrespectful treatment, failure to listen. So a common theme from patients, whether they're in Manchester, Liverpool, Coventry, Bristol, Bath, was, are you really in pain? You look okay. A sort of common factor. And I have to tell you, this racism point is not anybody playing a race card. And I'll tell you why. The healthcare professionals who look after people with sickle cell gave evidence that they witnessed some of their colleagues behaving in that way. So it wasn't just patients saying, look, this is what we experience. It was healthcare professionals confirming they had witnessed that behavior in practice. And the final point was simply inadequate investment in sickle cell care. So over the decades, there's been limited investment in sickle cell services. It's been very difficult to fully staff sickle cell services and invest in things like psychology and more consultants and very limited research and development, because there's only one licensed treatment up to November last year for sickle cell, which is hydroxyurea, which wasn't really even invented for sickle cell. It's a chemotherapy drug. So that is an example of some of the investment. And then the final thing to say is that the all-party parliamentary group's report has begun to have an impact. Why? Because Pat McFadden secured a Westminster Hall debate in Parliament and said to the Secretary of State, have you read this report and how awful? And the Secretary of State, give him his due, said, no, I haven't read it. I will read it and I'll come back with a response. So Pat McFadden and I met with the Secretary of State and there is going to be an action plan for improvements that is being led by the Health Inequalities team at the Department of Health and Social Care. The other thing that came out of the report is that on Sunday, for the very, very first time, the NHS England have launched a campaign called Could It Be Sickle Cell? That campaign is aimed specifically at healthcare professionals. So many of you will see in the national campaigns around stroke, which have existed for a while. And in my context about avoidable deaths, they've decided that there should be a national campaign to try and educate and make more aware healthcare professionals of the issues of sickle cell and the complications. So there were 31 recommendations in all. Some are to do with the Nursing and Midwifery Council, the GMC, those relate to training. The National Health Service Race and Health Observatory, there was a recommendation for them to commission some work to assess the extent of racism and the effect on health outcomes. They've put their hands up and said they are going to do that and accept the recommendation made by the parliamentarians. So it is beginning to have an impact. There's still work to do, but it is beginning to have an impact, and we won't rest until we get each of those 31 recommendations passed through as quickly as possible. So hopefully in that summary, I've given you an overview about the impact of COVID-19 on the sickle cell community. But I've also given you the latest information about the continuing challenges for people who live with sickle cell in terms of their care and experience and outcomes within the NHS. So I'll stop there, Malcolm, and if anything because I didn't use slide, if anything in that is not clear and anything you want clarified, please do. Otherwise, I'd welcome any comments, any questions, and we can have a conversation about it.
Thank you so much. Well, we got a hand up already from Abigail. Abigail, can you hear me? No, your hand is up. Okay.
That's it. I'm so sorry.
Hello, Abigail.
Hello, sorry. I'm sitting here eating a snack, hence why I've turned my camera off. I'm so sorry, and I must put my hand up by accident. I do apologise.
Oh, so you did have. Do you have a question?
No, I'm so sorry.
Okay.
I'm just saying.
Okay, never mind.
Sorry.
Okay, never mind. Okay, fine. John, one thing which would be interesting to know is certainly in London and I presume across the country, there are a lot of local sickle cell groups, often in centres near hospitals or in the local community. And I just wonder whether those groups have had or are having impact. I mean, sometimes they seem like sort of social groups, a place to meet together. But are they groups that tend to challenge what's happening in their local hospital or local health services?
That's a very good question, Malcolm. So we as the national charity have about 40 groups under our umbrella from across the country, including London. So sort of we because those groups that Malcolm is mentioning might cover an area or be linked to a hospital trust. So some trusts will have their own patient group and so forth. And the truth is that to use your word, some of them are social groups. They can have an impact with their local hospital. Where they work well, they can have a local impact with their hospital and what their hospital does. And that's a positive thing. And we congratulate those who do that. But the point is that sickle cell is such an unpredictable condition that the vast majority of people on those groups live with sickle cell and they're ill at times. So the frequency and continuity is not easy for them. And we advocate trying to get them to be more organised and better resourced so they can be more effective. But there are some really effective groups out there in their local areas. Others not so, but the not so is not because they, it's not their fault, but it may be to do with illness, it may be to do with capacity, and it may be to do with how the relationships work with the hospital.
Yeah. Okay, thank you very much. We got a question from Joseph and then Logie. Joseph.
Yeah, hello, John. Thanks for your presentation. I just wanted to say a bit about COVID. So I'm on the committee of Zero COVID UK, which is now being renamed Zero COVID Action. And COVID has not gone away. I mean, the latest figures last week from Independent Sage were that 619,000 people have died from the Omicron variant alone. I mean, this is the variant that's supposed to be milder. And although it's primarily an airborne virus, it is actually a blood disease. When it actually, gets into the system, it causes extensive blood clots, strokes, problems with the heart and various organs and so on. So it is, it's quite a nasty and serious illness. And of course, the statistics presented by Independent Sage show you won't be surprised to learn that its impact is much larger in deprived communities, and particularly among Black and minority ethnic groups, because when there's very cramped housing and things like that, it's allowed free reign in situations like that. one of the things we're concerned about is working with disability organizations like your own to try and combat COVID, to try and make, you know, people aware that it's still there, to make the authorities bring in things like mitigations and masks and so on. I mean, it's incredible to me that the hospitals have recently been advised to tell staff to stop wearing masks. And I had a story last week of somebody who went to a vaccination center and was this was a clinically vulnerable person, was told to remove their mask by vaccination staff, which is just, you know, unbelievable in my opinion. But I wanted to ask you, John, if the Sickle Cell Society would be interested in coming on board with our campaign, possibly having a representative in our committee, and if so, you know, should we approach you, or is there anyone else who we could talk to?
Thank you, Joseph. Well, first of all, and I'll answer specifically your question, but first of all, let me say in my overview about COVID and talking about where we are today with government policy, I made the point that our position is clear to tell people to be cautious and protect themselves, because it hasn't, as you quite rightly say, hasn't gone away, and that remains our position. And to illustrate a point, I was in another part of Europe for 2 days last week. Everybody on the metro wore a mask. There wasn't anybody not wearing a mask. Contrast that to you know, London, where, you know, that's not the case. So our advice to people who live with sickle cell remains the same, even though we're in that. So that's the first thing I would say, because that was something I said in my presentation. The second thing that I would say is that if you email, Malcolm's got my email, if you email me, it may not be that we've got the capacity to be part of the group, but we know some of our members who might be. So happy to look at that, and happy for you to email me direct about that. Yeah, so I think that answers your question, Joseph. I see there was a question from Lola, but I'm happy to come back in the chat. I'm happy to come back to that when you tell me to, Malcolm.
Okay, let's just take Logi's question and then we'll go to Lola. Logi.
Yeah, the question, I have two questions. One is the number of people admitted at COVID for sickle cell. Do you know how many people admitted, how many people sadly lost their lives?
The number who lost their life in the data from March 2020 to January 21 was no more than 6 or 7, because the vast majority survived. That's what the data showed when I said 97%. It was a small number, which is why, Logie, we said we were relieved, because if you go back to Joseph's point earlier, you know, one of the reasons we were concerned was that we knew that it disproportionately affected people from deprived communities and diverse communities. So we knew that, and we thought the impact could be larger. But that's why I say at the end of the day, we were relieved.
The other one is on the sickle cell. I just read an article today from NHS, the CEO of NHS, Amanda Bishard, and started a campaign. That one.
Yes, well, I have to tell you that.
I think she said a lot of people are not aware of it, and she's having a campaign, people teach people about, yeah.
And that's why I said the recommendations of the parliamentary report and my reference to the DHSC, we've been working with them about a campaign. It's a first. It's not, they've never done a campaign before, and it's long overdue. So as part of that, we couldn't do that campaign because it costs a lot of money, more money than the Sickle Cell Society takes to run. So we said one thing you could do is to do this national campaign to educate healthcare professionals principally, and they've done that. And Amanda Pritchard, who back in the day, Malcolm, I mean, I've worked with Amanda Pritchard when I was in the health service. So what's important about that, Logie, is that we have the chief executive of the NHS talking nationally about sickle cell. We have the Secretary of State for Health and Social Care talking about sickle cell. So this is unheard of. So, you know, our job is to keep those conversations going, and to, you know, and why is to hold them to account. You know, they're being held to account because we have evidence. You have to have evidence, because everybody can say this, that, and the other, but we've provided the evidence, both written, oral, we've collated that evidence. Healthcare professionals have confirmed what we've said, so we haven't said any. And what we have to do as a patient organisation is work within the system to keep holding them to account, because otherwise they could think, well, we've done a campaign, we can just forget about it now. So we have to keep the pressure on. And I have to tell you, that report that the parliamentarians did has helped the NHS, because I can tell you some trusts have got new consultants out of it, they've got new nurses out of it, they've got psychologists out of it. None of that's coming to the Sickle Cell Society, but the impact has helped some under-resourced services strengthen their local services. So, you know, and that's from a patient organisation.
Yeah, that's what I think.
Well, one second, Logie, just hold a second. Somebody has got is producing some noise. So if you're not already muted, could you please mute, because we can hear voices. At least I can hear voices.
Yeah, just a quick what I was thinking now that I know about that, I'm going to speak to my hospitals and find out whether they have any awareness course there. Okay, thank you.
Okay, Logie, thank you so much. Now.
Hello.
Hello, who is that?
My name's Dee. Am I able to ask a question quickly, if that's okay?
Yeah, of course you can. Yeah, of course you can.
Okay. It's a bit of a complex situation.
Can you just tell us your name?
My name's Dion.
Theon.
Yeah.
Okay, thank you so much. Carry on.
I've been given your details by a family member, and I'm just querying. We're finding it really hard to locate information to see if we can get continuation of care in Nigeria. My brother, he's been a citizen for 30 years in the country. He's now subject to deportation. But
Theon, hang on. Theon, hang on. This is a meeting about sickle cell.
He has sickle cell.
Okay.
So I'm just asking about.
Okay, carry on.
I'm asking if he's on that new medication. I think it's called Yovel, YEOV. It begins with the real name begins with a C. I can give it to you.
Crisinobab. It's called Crisinobab.
That's it. I just wanted to know: is there a likelihood that medication can be continued? Is it available in Nigeria? Is there any? I'm trying to get this information, and I'm finding it really hard to locate it.
It is hard to locate it, Dion. It is hard to locate it. And the only answer I can give you, it may not be one that, you know, is so clear, is that it's taken us ages to get a second drug, Crisinobab, approved and licensed in the UK, and there's more work being done to collect it. So there are now 2 available licensed treatment, hydroxyurea, which I mentioned in my talk, and Crisinobab. Now, the second bit of the point is availability. So it is available under the NHS. In Nigeria, I doubt whether it will be available without any cost. And the reason I say that is hydroxyurea, which has been around, is effective, is safe, and very cheap as a drug to countries is what I'm talking about when I say cheap. It's not an expensive treatment. That isn't widely available in Nigeria. So you can get it. But so the point that I'm making to you is that I can't speak for Nigeria. And of course, different states in Nigeria have different rules. So he would have to, or she, your relative would have to speak to a specialist sickle doctor in Nigeria to get the information. It's very difficult to get that online and through ways. I'm pleased though that he's getting it whilst he's here, and I hope he's making some progress as a consequence.
And if it was to stop, would there be any bad consequence?
If it was to stop, then if it was to stop in the UK,
but he's already having it, and if he was to go home and then not have it, would that have a negative effect for him?
I don't know the answer to that. All I would say is that this is a new treatment that was only available from February of this year. It was approved in November of last year, made available in about February. So he would have been receiving, or she would have been receiving, presumably hydroxyurea or transfusions or some other standard of care before that. So if one returns to Nigeria and it's not available, or it's beyond the financial means, I would suspect that it will be another standard form of treatment.
Okay. Thank you so much for that, John. Thank you very much for your question.
Can I just finish, please? Is there anywhere that I could go to obtain further information in relation to that? Like, is the Sickle Cell Society would
you've cut off.
Be able to give me further
information. We've got. I don't have it in front of me, Dion, but if you email info@Sickle Cell Society, we've got some links with organisations in Nigeria who may be able to help. I don't know if they can, but we certainly have links with organisations in Nigeria who might be able to help.
Thank you so much. Thank you. Thank you.
And Thean, thank you so much for your question. Now we got a question from Lola only. I'll read the question out. The question is, are you there, Lola?
Yes, I am, but I was hoping you'd ask the question for me. But I'm going
to do that right now.
Okay, that's fine.
Lola asks, how do we monitor and ensure NHS England remains accountable, brackets reporting to user reps, and there are repercussions for providers who fail to achieve, one moment, I'm just going to go down a little bit, who fail to achieve national standards consistently.
Okay, all right, and I think I've touched on this. Hello, Lola. Good to have you on the call. I think the answer to that question is we. You know, this has been an issue going back to when you, me, and Malcolm were at King's. This isn't a new issue, and we're beginning to hold them to account. So when I reference the chief executive of the NHS. And the Secretary of State saying, yeah, things need to improve. There's been a campaign that was launched yesterday, which we've been working on them. But I think, to your point, there does need to be some repercussion is the word that you use, but there needs to be ways of holding trust to account for not meeting the A&E standards. I think it is a disgrace, and I've said it's a disgrace, that, you know, and we're talking, Lola, specialist centres as well. So you might have a great specialist centre with great sickle nurse specialists, great consultants, but then you have a crap time, sorry about my language, in A&E. Yeah. So our view as an organisation is we want the commissioners of sickle cell, and I've made this point, to find a way of holding trust to account who consistently fail to meet the NICE guidelines. If they met the NICE guidelines, just on pain relief, that would make a remarkable improvement to the care. So I think that's what we're working for, and I think the 31 recommendations from the parliamentary report make recommendations that mean we can say, if you're not going to make this if you're not going to deal with this recommendation, well, tell us what you are going to do. So the fact that we've made the recommendation doesn't mean that if they say we're not going to do it, we're just going to leave it. We're going to be pushing, as I said, to make sure all those recommendations are clear. And as a nurse, I think, and I'm happy to say so publicly, I think the Nursing and Midwifery Council, of which I was a member of that council, a lay member of that council, are sitting on their hands and doing nothing.
Precisely.
I'm not ashamed to say that. They would be shocked, but they're sitting on their hands. Training needs to improve. Sickle needs to be not something that is just left to colleges to decide whether they're going to teach or not. So there you go. It's not just the trust. It's not just the trust, Lola. It's people like the DHSC. It's people like Nursing and Midwifery Council.
Well, you know where we stand on that, because we've had meetings with the NMC, as you know, and they didn't take up the baton at all. So I don't know where one would go in terms of that now.
Well, we'll keep saying what we're doing. I mean, I think their strategy, is to say, oh, we're doing what we can, but I think doing what we can is not good enough, and I think we have to be brave enough to call it out and say it's not good enough. And at some point, they're gonna have to do something, and particularly, as I mentioned in my presentation, particularly if, as a consequence of lack of training and education of healthcare professionals, say in A&E or on a general medicine ward, there are more avoidable deaths. Why should there be avoidable deaths? Because we don't want to give more training, So I think the accountability is with trust, and it's with people and organisations like NNC, GMC, and so on.
John, then has this issue been brought up with the all-party parliamentary group?
Yes, that's absolutely. That was one of the 31 recommendations.
Right.
Mark.
Okay. And I wonder whether we should also raise the issue with Healthwatch England to ask them to.
Yes, that would be very helpful, because the more Malcolm from different quarters, the better it is.
Okay.
That would be very helpful. And if you want to share with them a copy of the No One's Listening report, it is on our website, or if you can't find it, just drop me an email and we'll send you the full report with its recommendations.
We can do that this week. Sister Josephine, you've got a question. I can't hear you. You're on mute. That's it.
Hello, everyone. Thank you, John, for the presentation.
My pleasure, Sister Josephine.
I need to congratulate you and your team for coming so far. It shows how much work you have put in, because as Malcolm will remember, the forum has been working a lot with the London Ambulance around sickle cell issues. And I'm glad to hear you say there've been improvements, especially around the COVID time, when the challenges and the fears were so much, even among people who were healthy. But for the sickle cell patients to have come through, I'm really happy to hear that. What we need to do, I'm glad Malcolm has said it, because I was going to recommend that we as the forum do something more to support what you are doing at the moment, and to hold them accountable for what they say they want to do. This is a great time for us to hold our politicians and our healthcare professionals, especially with Amanda Pritchard, who has been on the shop floor, I would say, knowing what is happening. She should be able to speak up more than what she's doing at the moment. So I will recommend, and I will follow up with Malcolm, that we do something to support your work.
Thank you, Sister Josephine. That's very helpful. And I think Malcolm's suggestion and your suggestion about contacting Health Watch,
Yes.
the national body, would be very helpful. And just to give you and the audience an example of changes within the LAS, as a result of no one's listening, the LAS, so I was talking to Lola about NMC and them sitting on their hands, the LAS are looking to see how they can integrate sickle cell training for everybody at sort of pre-registration level and so forth. So they are saying, they're not saying, oh, well, we're not sure. They're saying, actually, this is something that we could do something about, not just the London Ambulance Service. This is the people who set the training requirements for paramedics. So that's a good thing. And like you, as I said in my presentation, we were relieved that there were only a few deaths in the cohort study data from March to 2021.
Okay, thank you, John. We got a question from Ines.
Okay.
Are you there?
Yes, I am here.
Can't see you.
What you can't see me, right? What I want to ask is that when Edward was admitted, was there any treatment laid out for sickle cell, or we should be treated for sickle cell?
Sorry, when who?
Edward was the one for sickle cell when he was admitted in hospital because he died, isn't it?
Yes, yes.
Evan.
Oh, Evan.
Okay, sorry, I did. Evan.
Evan.
When Evan
was there any
admitted,
treatment laid out for him? Oh,
well, that's a very good question. That's a really very good question, because Evan, his parents, Betty and Charles, we know very well and worked with Betty and Charles. There is standards, as Lola knows, I know there are standards for admission in A&E, and there are standards about the care that he should get when, the point that I'm making is that there's a failure a lot of times to comply with those standards, and in Evan's case, the contributory factors to his sad passing was a lack of communication between the ward team who were looking after him and the hematologist. So that's that, you know, so there are standards, but in Evan's case, there was a lack of communication between the ward team who were looking after him and the hematologist, because he was there also for some gallstone issues. And the second reason is nobody on the ward was listening to him about the pain that he was suffering from his crisis, which is why he resorted in desperation to call 999. Those were contributory factors to his sad passing.
Okay.
But the answer to your question, whether it's North Mid or St Elsewhere Hospital, is that there are standards about how people with sickle cell should be treated. The point that I'm making is that many healthcare professionals don't comply with those standards.
That's it.
Thank you very much. Are there other questions, please?
Georgina's got her hand up.
Georgina, that's Ines, who's just now
spoken. That's the question I was going to ask about Evan, and so that's why Georgina's hands were up, really.
Okay.
Yeah, you've answered the question. Thank you.
No, pleasure. My pleasure.
Hey, are you there, Sam? Samad? No.
Yes, I am.
Oh, you are.
I am Malcolm. Yes, I am
so
Malcolm.
much.
I'm here.
Good. I wondered whether there are any sort of issues you'd like to raise in relation to the work of the London Ambulance Service.
I think I'm going to keep them for the time when I'll talk about it.
Okay. Okay. Fine. Yes. Sam will be. Sam
That
will
would
be
be-
speaking at one of our future meetings.
Yeah, that would make much more sense then.
Okay, that'll be absolutely fine.
Thank you, Malcolm.
Okay. Any other questions anybody would like to ask, please? This is such a rare opportunity. Take advantage of it.
Yes, please. Malcolm, yeah. It will be helpful, I think, if we follow up on the Dion's question about continued care. I don't know, James or John, how you see that question, but I think it's very important for people with sickle cell anemia to have a package. If that could be done, I think that would be wonderful improvement in terms of how sickle cell has come from the beginning to now, that we have people able to live their lives longer and also able to manage their lives at home. So us working on a package for them to take on holidays or take away with them, I think that might be helpful. I don't know if research could help with that.
Do you mean a package as like a care plan?
Yeah, because Dion, what Dion is asking is related, apart from the new drug, I think she will also like to know what care packages or what continued care, because she mentioned the word continued care. So could we look into that as well?
I think it's John here, Malcolm, just to help you. I think Dion was talking about continued care from the UK to Nigeria, is the first point. The second point is that as part of the campaign launched by NHS England, which we've been working on them, they are working on reissuing cards for people with sickle cell. So if somebody goes on holiday to Blackpool or somewhere, they can show, they don't have to have people asking them sort of the same question over and over and over again. But I think your first point in your original question was to get Health Watch England to push for greater improvement based on the No One's Listening report. Because as I was saying earlier, there are standards, but the issue is getting healthcare compliance at trust level and policy changed at national level. If those two things happen, I can tell you now, Sister Josephine, that would be a step change for many people, because the evidence that the parliamentarians had was that some people try to treat serious crisis at home because it's such a nightmare going to A&E and going through that process.
Yes, thank you very much.
Just to take this another step forward, so there is this system which is run across the country whereby people through their GP arrange for information about them to be on the NHS system. So, for example, if they might be in a situation where they're going to call 999 and end up in hospital, that when their call goes through to the LAS headquarters, that their details are already on the system. So they know what their previous history is and they know what medications suit them best. Is that a system that you've been advising people to participate in?
Well, not that specific system, Malcolm. For sickle cell, there is something called a national hemoglobinopathy register, which is a national register. It's good because in France and United States, they don't have such a national register. They might have local registers and stuff. So it's a good tool. And what we've been working with the National Hemoglobinopathy Register is to try and make that information in the register available to patients, because at the moment it's only available to healthcare professionals. So we're trying to work with the NHR to so patients can access the data, but more importantly, that they can access it in an electronic way. So if the person travels from London to Cumbria on holiday and becomes ill, then they can show the information that is necessary without having to repeat themselves. So we're working on that. It's a slightly different system to the one that you described,
Okay.
but would have a similar purpose, Malcolm.
Okay, there's a question there from Lola.
So it's not so much a question, it's in response to that issue
All right,
about the, Dion's brother. Since Dion is already receiving care in the UK, his care provider now, the consultant that looks after him now, can give him the same information that he needs to take with him to Nigeria. So he will be able to take details of his care to date and his current care and take that with him wherever he goes. Most consultants will do that in any healthcare system, at least until, you know, the register issue becomes more live. There is that option available to him.
Yeah, okay. Thank you very much. Hello, Kai. Welcome. You were there a moment ago. Are you there, Kai? Right. I can see your name, but can't hear you.
Just whilst Malcolm, there's a question.
Hi, Malcolm.
Hello, Kai.
Right, okay.
Nice to see you. I mean, nice to hear you.
Yeah, thank you for saying hi in any case, but you carry on.
Hello,
I'm
Kai.
in a
Nice
place
to
where I
see you,
can
sir.
speak at the moment, but I'm listening.
Okay. Just for everybody, Kai is the chair of the Sickle Cell Society.
Past chair.
Sorry, here's the past chair.
Nice to see you, Kai. Listen, Malcolm, there was a question from Lyndon Bowen, and I'll answer it because what Lyndon has asked is that are there standards across the board rather than varying standards? And the answer to that is yes, there is a single set of guidelines for sickle cell that can be used whether you're in Hackney, Liverpool, Manchester, Birmingham, wherever. There's a single single set.
Right. Okay. And we don't have any more in the box. No, I don't think so. I think that looks like all the questions that are coming in.
Malcolm, I might have to pose a short question, which may have been addressed. So it is Ade here. Hi there. So thanks, John. Ever so engaging discussion here. And it's very nice to hear that there's a lot of appetite now for the government doing something about the sickle cells experience. My question really is about the ICS build. So we're very aware of where we're heading for with the new NHS framework of developing ICSs and the ICBs being the people to hold the ICSs to account. So my point, I think, speaks to what Lola asked us earlier on. How do we hold them accountable? And more so, how do we engage more with them? Because I think this is an opportunity for us to actually take what we've got and put that before each ICS and make them see the need to embed such a kind of initiative within their systems moving forward. And perhaps we can have some exemplary ones that would want to show how they can do it well. So my point really is about engagement and how do we see this coming through? Thank you.
That's a really good question and one that we have grappled with. And of all the ICSs, Ade, there are probably 3 that we're doing work with. The rest, and again, I'm being frank, I'm always frank, are talking to the usual people that they talk to. So I think we have a lot more work to do. It's very difficult to engage people who are, or organizations who say one thing, but say it for political purposes rather than do anything about it. So I think and I have made this point to the King's Fund, because the King's Fund have been doing an analysis of the creation of ICSs and how inclusive they are. And one of my challenges is that many ICSs talk to the same people that they've talked to, and sickle cell in many CCGs as they were, wasn't interest, even in high prevalence areas, even in interest. So I'm saying it's good news that we're engaging with 3, but that engagement to date hasn't produced any additional resources. But the difference now, Andy, the difference now is we were pursuing that engagement with CCGs. The difference now is that nationally, through the NHS Chief Executive, through the Secretary of State, through the campaign, there is more, if you like, higher level push on sickle, which hadn't, it felt to us like we were rolling a boulder up the hill. So I think it would be fair to say that there is more work to do with ICSs, but I think the national conversations about the need for change from DHSC, NHS England will help further engagement with the ones that are less keen to engage, even if they say so. But the final thing to say to the point about Lola, that shouldn't preclude holding individual trust to account for simple things like compliance. As I said, it's a disgrace that less than a third can't even give pain relief on time. And people might say, well, no, we're so busy, we've got busy A&E departments and there's COVID. Well, actually, it was happening before COVID, so COVID isn't an excuse.
John, I mean, a suggestion is, I don't know if you've done any work with Marie Gabrielle in Northeast London.
Yes, she's one of the ones that we're working with. I've known Marie for many years. So the East London ICS is one that we're working. Marie is understands the issues.
Yeah, I think so, and I think she's very committed to high level public involvement. So I think we might actually encourage her to spread the word to other chairs of ICSs across the country.
Indeed.
Sorry, John, I think could you explain ICS, because there may be members of the audience who don't know what ICS is.
Yep. The ICSs are, let me start by saying they're the reorganisation of the NHS, where trusts and commissioners covering a geographical area partner and collaborate. So the difference is, instead of competition, all those organisations in there. So you might be a NHS hospital trust or a community provider and the voluntary sector, but to Ade's point, many of them only talk to the voluntary sector they want to talk to, not people like us. That all those organisations club together to improve health and health outcomes for that population, focusing on neighbourhoods that are particularly challenged.
Integrated care system, ICS.
Integrated Care Partnership and Integrated Care Board. Lyndon Bowen, you raise a question about all these abbreviations. You're quite right, and apologies to you. We should be more careful how we communicate.
Indeed, quite right, Lyndon.
Yeah. Right. Are we done, or are there any more questions? I think we're done.
Okay. Well,
John, thank you very much.
No, it's been my absolute pleasure. I always enjoy seeing you, Malcolm, as well as Kai and Lola, who I used to see regularly, but not so regularly now. And Adi, I haven't seen for such a long time. So it's my pleasure to have joined you all. You've asked some really searching questions, but what it identifies is there's still a lot of work to do. We're making some improvement, but there's still it's still a long way to go. So thank you for listening and being attentive and asking me all these wonderful questions.
It reminds me, John, in the I think the early 90s, when we had marches across South London.
Indeed, I remember them
in order to get improved sickle cell services.
Indeed, I remember them well.
I remember a march led by Rhoda Gangan.
Yeah, yeah.
And we had public meetings in Lambeth and Southwark town halls, which were very well attended with outstanding speakers.
And when we were there, you might not remember this, when we were there, we planted the seed for there to be a chair in Sickle Cell. And King's appointed a chair in Sickle Cell, and then that chair left to go to America, no replacement. So that tells you something. But anyway, it's been lovely to see you all. Thank you all for logging on. Thank you for your questions, and I wish you a great evening. Keep up the work. We've got to keep up the fight, as they say.
Right. John, thank you very much. Thank you very much, everybody, for coming.
Us.
Thank you.
Bye-bye.
Cheers.
Thank you for inviting us, Malcolm.
Bye-bye. All the best.
Do you want to stay on, Malcolm?
Sorry, somebody was asking.
It's me. Do you want to stay on?
Do I want to stay on?
Yeah, please.
Yeah, okay, I'll stay on, yes.
See you, Malcolm.
Koffo, did you have a question, or were you?
Oh, no, I was just saying bye.
Okay, bye, Koffo. Bye. Bye, Kai.
Bye-bye. It's a great session. Well done, Alistair.
Okay.
Well done.
Great to see you. See you soon, I hope.
I hope so. Take care. Bye-bye.
Bye-bye. Okay, sign off, please.
All right, Malcolm.
Goodbye.
Bye. Thank you.
See you soon.
Okay, bye.
We'll share notes.
Bye, everyone. Bye, Alan. Thank you. Nice to see you again.
Bye.
Yeah.
Bye, Polly.
Polly. Bye. Bye.
Bye-bye.
Okay.
And Lyndon. And
Lyndon.
Robin.
Yeah. Bye. Robin is there as well. Good. Thank you, Robin. Bye, Malcolm.
Bye-bye. See you soon.
Bye.
Robin. Are you there, Robin? Well, Alan, thank you so much. That went very well.
Yes, it did. He's a very engaging speaker, isn't he?
Yeah, he is. Yeah. It's one of those times when, you know, he was, I think, deputy chief executive of King's when I was in the CHC. So we kind of engaged in what at the time was a very hostile environment. But we managed to keep the engagement going over the years. And it's brought along a lot of, I mean, a lot of those people there. I mean, like Kai is an amazing person, is the former chair. Suffered a terrible tragedy when his, some years ago now, that there was a flood in part of Surrey where he lives. I think the River Thames flooded, and the water ran onto some ground behind where he lives. And hydrogen cyanide was released from the ground, which killed his son.
Oh, God.
Who was, I think, at the time was about 6 years old, and resulted in Kai being paralyzed below the waist. And he's been fighting a battle for justice for his son ever since. Faced kind of enormous resistance to investigations and.
You told me about this once before. Wasn't there some question about whether it was cyanide or not?
Well, I don't know. At the time, there were differences of opinion, but the people who did the research refused to publish their papers or refused to share their papers. So, I mean, he's got very high level support. I don't know what the current situation is, but he's been fighting for justice for his son for many years now. So we're going to, I think the turnout